Okay, so we are here to have a hangout on air with three guest experts to talk about program evaluation. My name is Lainey Yaris, and I'm the Chief Strategic Officer for the Faculty Incubator and core mentor for this month, along with Megan Osborn, who is joining us. Megan is the Program Director for Emergency Medicine at UCI. And we also have with us today George Mejicano, who is the Senior Associate Dean for Education at OHSU in Portland, Oregon, and Chad Kessler, who's the National Director for Emergency Medicine for the VA. So the first thing I'd like to do is have everyone individually go ahead and talk a little bit about your views on program evaluation and how you currently do program evaluation in your roles. We'll start with George.
Hi, everyone, and it's great to be here. It's a complicated question, Lainey, because it depends on what the outcome that you're looking for is. There's a number of different kinds of program evaluations. So you have to know what the stakeholders are trying to look at. So let me give you an example. You can look at it through an accreditation lens. You can look at it through, for example, a resource allocation lens. So it really depends on which one you're looking at. So it's very useful, but you have to understand what the stakeholders want before going forward with one of these kind of evaluations.
Great. Megan?
Well, first, I think it's really important to differentiate between evaluation and assessment. Oftentimes we use the word evaluation when we really mean assessment. So I just want to clarify for our faculty incubators what the difference between those two is. And when we're talking about evaluation, we're talking about evaluating programs. And when we're talking about assessment, we're talking about assessing learners and learner outcomes. And oftentimes assessment is within an evaluation. You want to look at your assessment pieces when you're looking at an overall evaluation, but the two aren't completely interchangeable, especially when you're speaking within medical education. So after that point of clarification, what we do within our program for evaluation is for our residency program. I also have a curriculum course in the fourth year medical school that we do a program evaluation as well. And so I agree with George, there's a lot of different pieces and you have to find out who stakeholders are. So for us, with our residency program, our stakeholders are our residents, our faculty, as well as the American Board of Emergency Medicine. And so when we design an evaluation, we kind of take all those pieces and we take all our pieces of learner assessment to formulate that into our annual program evaluation that we do.
Great. And Chad, can you share with us a little bit about how you use program evaluation in your role?
I sure can, but first I need to comment on Megan, spoken like a true MHPEer that she is with program evaluation and learner assessment. I gotta love it. Little shout out to the MHEP program in Chicago. In my role, I oversee a lot of folks. It's not just emergency medicine, say students, residents, physicians, nurses, healthcare techs. We have 143 EDs and all the people that come in there. Back in the day, it was more resident assessment or learner assessment. Now I think it's really turned into that program evaluation. And it becomes much more complicated when you're looking at multiple levels of learners, which is part of the education program that we both did, looks at how to assess people at multiple different levels, which becomes interesting. On different levels. So finding out what you're trying to do and who your audience is, and then working and trying to get some validity evidence about what you're assessing, whether again it's the learners or again the evaluation of that program is first and foremost. Once you know what you're doing, for example, we started an MCAST, an emergency medicine webcast for the VA. And we have providers from multiple different levels. We have internists, we have family physicians, emergency physicians, nurses, and our first talk is on trauma, trying to educate 153 hospitals with multiple people at those hospitals, and then finding out if they actually learned something is a challenge. And no matter how many people or hours you have, you can't just go and interview everybody. And so you have to work with some of the resources you have, given that large audience. In that case, it's some type of survey or a post-course evaluation. And I think that we still have to do that, although that might not be the best or top of the triangle or pyramid. There's ways that we can do that and make it rigorous. And so looking at ways to provide validity evidence for those questions, say in that example, would be how I'd pursue that.
Great. Thanks, Chad. So we talked to our faculty incubatees a little bit about their questions about program evaluation, and one of the sentiments that we heard is that the cohort is working on how to evaluate programs, curricula, everything from one lecture to a year-long curriculum, or even a 3 or 4 year-long curriculum for residency. And what you touched on, Chad, is exactly one of the questions that a lot of people are wondering. If we want to get beyond that first level of Kirkpatrick's pyramid and measure more than just satisfaction, but we are busy educators with not a lot of time, what are your tips for being able to successfully do that? And this is for anybody.
Well, let me just build real fast on sort of what I was saying before. We did an assessment and evaluation a while ago looking at consultation in the ED. And we did it pretty rigorously. It was part of the project for the program that we did in Chicago for the master's. And what we did was look at a checklist and then a global rating scale. And I think if you develop sort of objective tools that you can use them in an easier fashion with not a lot of people or man hours or woman hours to do that. And so if you have a tool for consultation or handoff or anything like that, it can be anything, then more than one person can give that out. It doesn't have to be your expert attending physician that might have a lot of time. Maybe you can use a fellow or a resident or whatever. If you have the evidence on that checklist or other item that you're using that's standardized, or even a global rating scale that's been standardized, multiple people can use it. And I think then it becomes out of, I need the top 10 educators in my department to be able to give out this handout or listen to them. Multiple people can do it. You can objectify the score, and then many people can use that tool. So if there's some way to develop a tool to assess a learner or a program, that's great. And then you can use it multiple times for multiple different people.
Yeah, this is George. A couple of comments. So the first is that there are databases and data streams that are being captured all the time. And the question is whether or not you can avail yourself of that. So for example, almost every hospital, I think all hospitals, have to look at, for example, blood utilization. They have to look at their proportion of patients that where guidelines are being followed. And so getting, if you will, on the minutes, in other words, receiving the minutes from all of the committees that your healthcare system is involved with can be very helpful, because there's often reports that you can use then to evaluate some component of your program or some sort of educational intervention. That's true for antibiotic utilization. That's true for quality improvement initiatives and things along those lines. In other words, you don't have to be the only one collecting data. The other piece I want to make here is that you mentioned Kirkpatrick specifically, but there are other variations of Kirkpatrick, and in particularly the one that I like is from Don Moore, Joe Green, and Harry Gallus in 2009 from JSEP, where they added the concept of return on investment, as well as other layers to Kirkpatrick's levels. And so you can start bringing things like, for example, how much money did it take, or what were the resources? And I'll just give you one quick example. If you were interviewing X number of residents for your emergency medicine GME program, do you know how much money was spent relative to that recruitment pool? And you can start looking at it through a fiscal lens, and that's again a different type of evaluation.
So I think that when we're talking about Kirkpatrick, I think that it's really important not to knock the first level. I think that sometimes learner satisfaction is a very valid outcome that is a valid measure for a program evaluation. For example, if you look at Chad, he's done a lot of work with consultation. And if you look at learner satisfaction with feeling comfortable and now calling a consult, I think that that's a very valid outcome. So even though that's not the best outcome, it's not highest on the pyramid, I think that we can still have some value in that level of the pyramid with our learners being satisfied with the educational outcome. And then also, when we get higher and higher, a lot of other variables that come in. And so we can't necessarily attribute the learning intervention with the outcome or the patient care outcome. So oftentimes it gets a little muddy when we go higher up on our pyramid. So I think even when we stay at the first two levels of the pyramid, it's not entirely bad.
So that's a great point. And there are some documents that are floating around on Slack right now related to program evaluation. And one of them is Dave Cook's editorial on the difference between patient-oriented outcomes and really the outcomes that truly matter in education research, and how sometimes those align and sometimes they don't. And so we will, afterwards, we'll make sure that we post all of these resources again so that people have access to them. To talk about a little bit of a different spin on it, one of the other questions from the cohort was to ask if we could explore ways to look at longer term outcomes when we're talking about program evaluation, either looking at outcomes longitudinally over time or looking at how learners perform or how they incorporate the curriculum at some point in the future. And what experience or tips do you have with those kinds of evaluation methods?
Well, I guess I'll start. This is George again. So I'm going to use the medical school as an example, or our medical school as an example. So the LCME requires, as an accreditation standard, long-term outcomes. So there are things, for example, on where, what was the proportion of the students that matched, and in what specialty, and in what choice was it? What were the USMLE scores? Where do they get their first job? Things along those lines. And soon, if the ACGME comes through with what they are hoping to do, we'll start to get milestone data of our graduates. So you can actually set up a system by which you can accrue long-term information about where the learners have gone, what they've accomplished, where they go. And a lot of residency programs do this because the classic question is, so after you're done, where do they get jobs? So the trick is to keep the connection with the learners beyond that first position. So you can, once you do that, you can start looking at things like board certification rates, MOC, and whether there's adverse actions from medical examining boards, all sorts of things that can go long term.
Megan, do you have any other thoughts?
Would you repeat the question again, Lainey?
So talking about like long-term outcomes, either continuous program evaluation for programs that are continuing and how to have a longitudinal plan rather than just we're going to evaluate it once and then kind of move on, or looking at your learners at times beyond just right after the curriculum. What tips do you have for either of those methods of program?
Oh gosh, yeah, I think George answered it really, really well. I think that's a really hard question, and that's what we all want as program leaders and as educational leaders, is we want our learners to go out and we want them to be a great physician 30 years from now. But how we get there, I think, is really difficult. And I think George mentioned a lot of different measures that we use. I think in emergency medicine, we're trying to map that out a little more long-term, and that's a work in progress. But I think it's really hard to measure right now.
Yeah, I think the long-term, I don't know if you want to call it the holy grail, but something like that is a career length portfolio of some sort, where all data would be accrued and be searchable across all clinicians. We're not there yet, but there's certainly people that are working on that kind of idea.
Well, to switch gears a little bit, George, I had a question specifically for you. With your role as Senior Associate Dean for Education, you kind of have a high-level view of the whole continuum from UME to CME and faculty development. And I'm wondering if you could just highlight for us what you think some of the big questions are for program evaluation right now with all the changes going on in medical education.
Sure. I'll give you three to start the conversation. Megan mentioned earlier this issue of attribution. How do you know if a particular intervention actually has led to a specific outcome? And I think with clinical data in particular, the attribution, in other words, what component of medical care is actually attributable to a specific learner, is a very difficult thing to get at. And so we need to be able to tag the data to individual learners. And then you can extrapolate from there and go to program, for example. So attribution, I think, is one very important and very difficult challenge that we're facing right now. The second one is a data sharing process, which is a little bit different. And let me be more specific. What I mean is this idea of a learner handoff. And so there are all sorts of, quote, rights / concerns around feeding data forward to the future, and whether it's a the milestone levels or achievement of an EPA or whatever it happens to be, many learners do not want that information shared forward to their future bosses. And so we need to basically get our an understanding of what can be shared, how can it be shared, what should it look like, what are the privacy issues. You know, and students have something called FERPA that protects them. Residents, it really is it's employment data, and so how do we get to that? So basically, data sharing is the second one, and the third one is specifically for the future of competency-based medical education is the issue of cohorts and off-cycle starts and stops. So this idea that classically all of you out there are probably assume that everyone will start on July 1st. Well, that's not the future. The future is people starting on October 1st and February 1st and November 1st. And so what do you do when you have learners at coming in and out at different points? And how do you essentially group them together? And what are the cohort effects? I think that's another major challenge. There's lots more, but I'll hold it to that.
Megan, do you have any big issues that pop into your mind too, other than what George has said?
I mean, I think that there's just so many issues, right? Like, so we're looking at a lot within graduate medical education, we're looking at a lot of quality and safety measures. I think overall, when we look at the Affordable Care Act, we're looking at a lot of different outcome measures that we're going to be measuring. So I think that it's such a huge question, and there are so many things on the horizon for what we need to measure in our program evaluations. But I think from an undergraduate medical education level and a graduate medical education level, George gave a lot of great points. And then I think just in general, continuing medical education, we're going to have a lot of data that we need to evaluate as well.
And Megan, to switch gears a little bit more, you just participated in launching a pretty exciting initiative for emergency medicine, JET-EM, which is offering our community opportunities to share curricula. And can you talk a little bit, as the editor-in-chief, can you describe what JET-EM is, and then talk a little bit about what kind of program evaluation data is helpful for people who are submitting curriculum materials or other pieces of work to your journal?
Thank you so much for bringing it up. Yeah, we're really excited. I think that emergency medicine education in general is doing so many amazing things with ALiEM and so many blogs out there, MCRED and MRAP, and there's so many different educational resources out there. And so the focus of JET-EM was a different tack. We wanted to focus on the educators and providing a repository for them for curricula and for team-based learning exercises, small group learning exercises, and how an educator in emergency medicine can just use a user-ready educational concept or a user-ready session that they can just take with minimal preparation and implement into their residency program. And so that's the goal of the journal. And we don't accept true quote-unquote research as a submission, but it's important when we're talking about program evaluation to include that data when you're giving a submission. So for example, if you are giving a curricula submission, for example, an ultrasound curriculum, well, we would want to know what sort of program evaluation you did on that curriculum, and how your just learner satisfaction, as well as any other measures that you did, like how well your residents now utilize ultrasound and how often they use ultrasound, and whether or not they had an improvement in their may happen for the ultrasound. And so those would all be measures that we would want to hear about when you're submitting something to JET-EM.
Great. And I guess final thoughts, what we hear from a lot of people who are trying to get started with program evaluation is just that it feels so intimidating. And so other than the strategies that we've talked about, using established tools, working together to develop tools, working on databases, do you have any tips for people just to kind of overcome that hurdle of not knowing how to get started?
I guess I'll start. I have a very simple way of thinking about this. Way back when I was a grad student in education, took a program evaluation class, and the point of an evaluation is actually to make decisions, right? So program evaluations allow someone to make a decision. So the way to think about it is what problem is there that you have that you're trying to solve? You can think about program evaluation from an improvement mindset, but you can also look at it from a solving problem mindset. And in the way I look at it, where I sit, it's easy to start things. It's far more difficult to stop things. And so I use evaluation data and program evaluation in order to make a determination of when to sunset. And I think using that lens can help people get started. What is the question that they're trying to solve? And then what data will convince you whether or not you can then make a decision about that. Because there's lots of things you can measure, but they may not help you actually make a decision. And so understanding that concept, I think, will help people get their heads around this.
I think those are really great points. I think one thing is planning for program evaluation. So when you're planning a program, planning to evaluate it. So when you're creating curriculum or you're creating a program, always having the plan for how you're going to evaluate it. And like George was saying, having an objective-based evaluation program. So what were your goals and objectives of the educational program? Are you meeting those goals and objectives? And that's a really, really simple way to look at it. But then also, I think if you're getting started, it can be very overwhelming because there are so many pieces of data that can go into a program evaluation. But the main thing is identifying your stakeholders and identifying who is the most important person to be involved in this evaluation, and who are we trying to tailor this evaluation towards. Because as George was saying, if this is an evaluation for the LCME, we're going to have a completely different evaluation than if this is an evaluation just within our program of my learners, and whether or not we need to include certain things in the future and not include certain things in the future. And so identifying who your stakeholders are, identifying who you're creating this evaluation for, are you meeting your goals and objectives, and not being overwhelmed by all the data that you do have, but just using that data as to whether that answers your question that George was talking about.
Yeah, one more. Those are great points, Megan. One more thing I'd like to say to help people think about this is understand the language of the stakeholders that you're thinking about, because different people are convinced by different kinds of data. Sometimes it's hearts and sometimes it's minds, meaning qualitative versus quantitative. And in business, they talk about, for example, the balanced scorecard, which are basically using 4 different dimensions to make a case for how things are going. And different people will be swayed by different kinds of data. Understanding that is very important, because you could spend a lot of money and a lot of resources and time collecting data that isn't going to sway anybody, because that's not what the language they think about.
Very true.
Well, thank you so much, Dr. Mejicano, Dr. Osborn, and Dr. Kessler, who just had to sign off. I think that we've covered a lot of big picture topics, as well as some really practical tips for our cohort to think about program evaluation in a little bit different way. And I really appreciate your time. As I mentioned already, we will post some resources after this talk on Slack so that you guys can all access them. And some of the resources that we've alluded to are not available, and we'll put those on there as well. So any other parting words, Megan or George?
Michael Quinn Patton. Michael Quinn Patton arguably is the, grandfather of programmatic evaluation. Has written a lot of classic books on it.
All right. Well, thank you so much. And this will conclude our Hangout on Air.
Thanks, Lainey.
Bye.